Hey everybody, welcome to the presentation on the pathophysiology of shock. As an introduction, it's necessary to know that all the components in our body are all interrelated and interdependent. There are no organs that are just independent. They all rely on one another. So, as we know, some of the pathophys into a lot of diseases, once one organ starts to fail or struggle, another one tries to step up and pick up the slack. So all of those organs are going to be working together to maintain your body's life. To maintain that life in the body, there has to be certain metabolism. That doesn't mean whether you're skinny or you're fat of how well you metabolize your food, but that's at the cellular level. So all that metabolism has to happen to create energy for our body. Now, when I talk about energy, that's not meaning some kind of hippie thought that we've got this weird energy or vibes about our body. It means that that's the energy, the fuel for our body. So all those cells in our body, they require energy to function. So all those little cells make up larger clusters that make up a whole organ. So every little piece of cell in every organ has to be getting energy to fully function, for that whole organ to fully function. The energy is stored within that cell in a form of adenosine triphosphate, or easily known as ATP. So that ATP comes from Krebs cycle. So that Krebs cycle is that oxygen and glucose equal that ATP. So all that happens in aerobic metabolism. So aerobic metabolism is where there is a presence of oxygen and that glucose to metabolize to produce that ATP, whereas anaerobic metabolism is in the presence of an inadequate amount of oxygen, which creates a decreased amount of ATP and accumulation of lactic acid. So think about those patients we've seen who are hypoxic, such as let's say a cardiac arrest patient. Do they have much ATP being produced? No. Okay, so the byproduct of that aerobic metabolism is CO2 and water, whereas the byproducts of that anaerobic metabolism is less energy production and lactic acid. For all that to be happening, you must have all the A's, the B's, the C's, everything in place. So you got to have a good patent airway so you can get that air in and out for the gas exchange to happen, to bring in oxygen for that aerobic metabolism to occur. And you must be able to have adequate expiration to get out the CO2, which is the byproduct of that aerobic metabolism occurring. And with that circulation, that's bringing the oxygen through to perfuse all those cells, and then that perfusion continues with the circulation to bring the CO2 back into the alveoli to exhale. During aerobic metabolism, when there is good amounts of oxygen, so that oxygen comes in, once it hits that alveolar capillary membrane, is where the gas exchange happens into the hemoglobin. So that hemoglobin comes through, it's carrying the CO2, diffusion happens, CO2 offloads, and creates space for that O2 to onload. So thinking about some of those, the pathophys of airway diseases, those COPDers and stuff, they have poor alveolar membranes, so they can retain that CO2 and not be able to unload that oxygen sometimes. And when that CO2 is in the plasma in the cells, that's from that byproduct of aerobic metabolism from Krebs cycle. So when that oxygen and the glucose combine and create that chemical reaction, one of the byproducts is water, the other being CO2, which is removed from our body during exhalation. So as a refresher, that Krebs cycle, oxygen and glucose equal ATP. That's a chemical reaction. So again, the byproduct of that is CO2, carbon dioxide, and water. Now, if you were to draw out the oxygen and the glucose in the chemical chain, so going back to chemistry class, You got your C's and your H's and all that other stuff. So we all know that every time there's generally a chemical reaction, there's a secondary reaction, which is heat. So that's why we're all warm-blooded, because of that Krebs cycle. At that cellular level, all that chemical reactions that's happening makes our body warm. So think about those patients you see, a diabetic patient. If their blood sugar is 30, are they producing much ATP? So do they have much energy? No. Do they have warm skin? No, because there's less chemical reaction, so there's less heat production. Along with good airway and breathing, the whole vascular system has to be in play for that metabolism to happen. One of the other big things is your heart has to be functioning properly. The whole vascular system as a whole needs to be in play well, because you got to have a good blood pressure to make all that stuff circulate, good pressure to make all that perfusion happen to get to all the cells it needs to. Because you can get the oxygen in, but if you're hypoperfusing and you're not getting that blood to the cells, then you're not fully in aerobic metabolism. So with that aerobic metabolism, good airway, good lungs, good circulation perfusion, good high amounts of ATP. Now, anaerobic metabolism, with that absence of oxygen, is using that stored glucose in the form of glycogen for energy production. So that is able to sustain some energy, just not for very long. It's got about a 19-fold decrease in energy with that high level of increased lactic acid as a byproduct. So back to those acidic patients who've hypoperfused for a long time, that's why they get bicarbs. That cardiac arrest patient that's been down, who've been in anaerobic metabolism for quite a while, have developed quite a bit of lactic acid. So with all that, much less energy production. And with that, shock is just inadequate energy production. The body's hypoperfusing, so there's inadequate energy production. Krebs cycle is not in full play, and you will begin to have cellular death. So under the microscope, there's a little bit of cells starting to die before we really ever see any major outward signs of anything happening. So when those cells are starting to die, they're becoming hypoxic. No ATP production, so in that decrease in chemical reaction, decrease in heat. That's why we're seeing these trauma patients who are hypoperfusing, who are hypothermic. So that, a condition with hypoperfusion is hypothermia, and that acidic buildup with that lower pH. As those cells continually hypoperfuse and that no energy production getting there, so no oxygen getting to those cells that are going on anaerobic metabolism, then they're able to get more sodium and water into that cell. So that cellular edema is getting much worse. And if we replenish too much fluid, we give them too much of a bolus, then we're creating more cellular edema, further worsening the whole process of it. And if it's not corrected, then you just have that continual cycle of the cells continuing to die. And acidosis continues, so what little bit of ATP is being produced, is little bit of reserves we have for energy, is being worn off from that patient shivering because they're becoming hypothermic due to no heat production from that Krebs cycle. And as that goes on, lactic acid continues to build up, and that acid's going to fight all the compensatory mechanisms in shock. So that vasoconstriction, everything else going on, that lactic acid is harmful against the muscles of those vessels. So when the vessels are trying to constrict down, they just can't because of all that lactic acid buildup. Thin coagulopathy, we want some natural clotting to be happening, especially internal bleeding, that we have no way to control that bleeding. So as that patient continues to become acidotic and hypothermic, that blood clotting becomes extremely impaired. So if you think about the platelets, which form the clots, if those platelets are getting cold, they're not going to want to stick together. That coagulation is not going to happen. So your platelets are just a lot like bubble gum. So if you got really warm bubble gum, those two pieces of bubble gum are going to become very tacky and stick together. But if they're cold, hard, cold pieces of gum, they just don't stick together. And it's just that continual cycle, that triangle death, or if you want to think of it, just that swirling motion of going down the drain. So we infamously say those patients are going down the drain, going down the toilet. It's just a downward spiral of acidosis, continuing into hypothermia, further worsening coagulopathy, and just a continual cycle. So that cascade where first anaerobic metabolism, then boom, trauma happens. Then we start going into anaerobic metabolism. With that decreased energy production, hypoperfusion, cellular death, bunch of cells start to die, a whole organ dies, and then, when all the organs die, the patient just dies too. With shock, there are multiple classifications of shock. So that's just any condition that's going to decrease cellular energy or create hypoperfusion. So the ones we see are hypovolemic, distributive, cardiogenic, whereas the ones we see in trauma are hemorrhagic, neurogenic, and that pump failure of cardiogenic. Hemorrhagic shock is by far the number one cause of traumatic hypoperfusion. And if you look in this little chart here, some pretty handy information. You see, you got 4 stages of shock: class 1, class 2, class 3, and class 4. So, we're not too much worried about urine output. We're not really able to measure that in the field. Hopefully, we're not taking the time to measure that. Pulse pressure, we can be feeling those pulses, seeing a little bit, but we're not going to focus on that too much right now. Blood volume, we can guess pretty well at this, but it's a good indicator just to think about for some materials later in this presentation. So your first stages in shock, what do you start to see this changing? Anything crazy? So ventilatory rate up maybe just a little bit. Even though we all put on our run sheets that all our patients are breathing 18 times a minute, when in reality they may only be breathing about 12 times a minute. So that respiratory rate's up maybe just a tad, and they're a little bit anxious. So at this point, that first compensatory mechanism's kicking in, that adrenergic receptors are kicking in, so we got adrenaline pumping through our body. So what happens when adrenaline's kicking through our body? Our heart rate starts to go up. We start to breathe a little bit faster, and we get a little bit more restless and a little bit more anxious. So some of those first signs you're going to see is that increased ventilatory rate, increased heart rate, and restlessness or anxiety from that epi kicking in. And your heart rate's going up, trying to maintain that cardiac output. So then when stuff really starts to get bad is here in the third stage of shock. So you see here about up to 2 liters of blood. So that's, if we have, on average 6 liters of blood in our body, that's 33% of our blood volume that we've lost. Quite significant. So that's where you're starting to see pretty significant tachycardia, and then the blood pressure drops. So here in these other areas, your heart rate was staying up, your ventilatory rate's up, because if your heart rate goes up, oxygen demand goes up, so you're going to breathe a little faster. So when your heart rate goes up and it's still trying to compensate for perfusion, so when our blood pressure drops, we're hypoperfusing. So then here, from stage 3 forward, stage 3, stage 4 shock, this is decompensated shock. They're anxious. This we're starting to see mental status changes. And then on here, you notice that there's no stage 5 shock, because after class 4 shock, it's just death. Now we'll talk about some injuries that are commonly associated with hemorrhagic shock. Fractures, number one that we're going to see in the field. So major or multiple fractures can lead to lots of blood loss. So, a major fracture could be a pelvic fracture, whereas a lot of people know pelvic fractures, you could lose up to over 2 liters of blood just from a pelvic fracture. A lot of hospital reports are coming out anymore to where around 50% of isolated pelvic fractures are fatal. So 50% of those people in the hospital who've broken their pelvis, they die. So at femur, the pelvis, lots of blood loss in there. So we can't just be underestimating that blood loss because we're not actually seeing any. We got to be very aggressive in monitoring our patient's conditions. A little quick chart of approximation of blood loss. So remember in the last slide, or a couple slides ago, talked about going into decompensated shock was estimated up to beginning at losing 2 liters of blood. So if you even just look here, one femur, you can end up losing up to 2 liters of blood, 2,000 milliliters of blood. So if you have bilateral femurs and a pelvis, yeah, you could end up losing a significant amount of blood loss. And then you think, well, if you got some smaller bones broke, not as big of a deal. But if you break a humerus and a radius ulna with that too, and you might even throw in a couple ribs, you could easily just get the decompensated shock by even just some of those less traumatic injuries that we think of. Aortic ruptures are generally caused from those uh, large sources of kinematics. So you got that patient who is in a vehicle at high speeds, rolled over multiple times. There's several directions of force acting, and basically all your guts, hearts, everything are just inside shaking all about, and it just rips apart. So this is a very, very, very fatal thing. So a lot of the patients that do have this occurred have died before we even arrive. So one way you can find this in patients and do a field diagnosis on this is if you think about the anatomy, how the body runs, when your aorta comes up out of your heart, it goes to bifurcation, then it goes to the left side and the right side. So if you've torn part of your aorta, if it's on that right side or the left side, it's going to have that tear in it. So wherever that tear is, there's going to be less blood going to one side or the other. So when you assess radial pulses equally in those trauma patients during your rapid trauma assessment, if you feel those radial pulses at the same time and one's weaker than the other, it could be a very good chance that there's an aortic tear in there. And of those who do survive though, 50% still die in that first 48 hours. It's very, very, very lethal. Hemothorax is, of course, we all know, bleeding into that thoracic cavity. So that's from blunt penetrating trauma, and each hemothorax can hold up to about 30-40% of a total patient's blood volume. So think about just how much blood can fit in your chest cavity. That 30-40% of total blood volume puts you straight into decompensated shock. So there again, you may not even see any external blood loss, and that patient's in decompensated shock. With those abdominal organs, the big ones we have to worry about are those solid organs of your liver, spleen, kidney, and pancreas. So think about in your body where all those are located. So who's right now, you're pointing on your body, thinking, okay, the liver's in the upper right quadrant, the spleen's in the upper left, kidneys are in the back flanks, pancreas is kind of right about in the middle. So think about what protects those. You know, all those important organs are under the rib cage. So by design, all of our really important organs in our body come with their own protective roll cage. Just to go with think about all the solid stuff is under your ribs. They're the protective barrier. Those ribs is that roll cage trying to protect all the really important stuff. Those solid organs can bleed heavily. And generally, remember with those solid organs, if they are damaged, a lot of times they're going to have pinpoint pain. They'll be able to point exactly where they hurt. Those hollow organs, a lot more diffuse pain. They can leak those contents and cause peritonitis. Not as big, not as generally as lethal as rupturing one of those solid organs. Now we'll talk about some injuries commonly associated with distributive shock. Neurogenic shock is the big one. So there is a loss of sympathetic vascular tone from damage to the spinal cord. So that brain sends a signal down to all the vessels telling them when they need to contract or constrict, dilate, whatever from those baroreceptors in the vessels. So if there is damage to that spinal cord, those signals are not going to or fro. Those afferent or efferent receptors aren't doing their job. So that brain's trying to send a signal down, tell the vessels what size to be, but they're not getting any answer. So the way I like to always explain that is that neurogenic shock is just kind of like when my wife leaves town. That brain's the boss, my wife's the boss. She tells me what to do, so when she's out of town, I just kind of sit back and relax. So with no signal coming from the brain to those vessels telling them what size to be, they just dilate. So when you have just sudden vasodilation, you're gonna have hypotension, hypoperfusion. And now those signals aren't getting back and forth to tell the heart that it needs to speed up. So the heart rate's gonna stay the same. Whereas in normal compensated shock, the heart rate's going up. So often in that neurogenic shock, you're not gonna see that heart rate go up, and that skin's gonna be red and flush still. If it's a lower injury, you can see two different skin tones. So if it's below the site of injury, so all those vessels below that site of injury have dilated. So what color is blood? Red. Those vessels are dilated below the site of injury, so wide open vessels, that path of least resistance. So all the blood's going to dump down into those dilated vessels. So where all the blood's at, it's going to be red and flushed. When blood leaves the skin, it leaves it pale and cool. So you may even notice some difference in skin tones. That may also be mimicked by beta blockers and other drugs. So, a normal compensatory shock, that heart rate's trying to go up, but if a patient's on beta blockers, it's controlling all those beta receptors that make, cause vasoconstriction and tachycardia. So they're trying to control their heart rate and their blood pressure. So that geriatric population taking beta blockers, when the body wants to compensate and increase the heart rate, those beta blockers are going to tell it no. So that patient's not going to be in compensated shock really much at all. They're going to go straight to decompensated shock. So with that neurogenic shock, you're going to see hypotension and a regular heart rate. If they're on beta blockers and they're bleeding internally or externally, wherever, you're not going to see that heart rate go up. So it might be kind of hard to diagnose those two in the field. Also, some other drugs can depress the body's compensatory mechanisms to try and increase the heart rate. Some other stimulant or depressant drugs, such as Xanax, meth. There's a lot of studies leading into that, to where patients are doing Xanax, meth, these other opiates, various things that just kind of depress the body, that don't allow those heart rates to go up. The body's not compensating in shock with those either. Now we'll move on to some injuries associated with cardiogenic shock. Pneumothorax, one of the most infamous ones, and we know that's air in the thoracic cavity. So the varying difference between when it goes to a tension pneumothorax is when you start to have cardiac compromise. That's when you're starting to get that JVD, because those lungs are shifting over and that it's getting tense from those lungs squeezing on it, all those tensile forces pushing, squeezing on that heart, so it can't open up as wide as it normally does for all that blood to dump down in. So those jugular veins become engorged because the blood backs up. The blood pressure is dropping because the systolic and diastolic contractions of that heart, it's not able to open up. It's being squeezed, so it can't open up for Sterling's law to take effect and get that good hard pulse out. Or simple pneumothorax, that's generally just your decrease in breath sounds, ventilatory distress, but there's no cardiac compromise. In straight cardiogenic shock, you've got your intrinsic and extrinsic factors that have caused that. Intrinsic is that blunt cardiac trauma leading to muscle damage or a dysrhythmia. So also like a myocardial infarction or somebody going into VTAC can cause cardiogenic shock, whereas that extrinsic factor is from direct trauma that causes a pericardial tamponade or that pneumothorax compressing on that heart. So the illustration here of that pericardial sac. So that pericardial sac surrounds the heart, and you think about any time you've ever been hit and there's swelling. So somebody punches you in the arm and you get that goose egg. A lot of times when there's a blunt force, there's edema that occurs. So with that pericardial tamponade, that pericardial sac that surrounds the heart is a really, really heavy, thick material that won't stretch. So within that pericardial sac, edema begins to develop. So since that sac won't stretch and that fluid begins to increase, it ends up squeezing the heart. So if you think about when that heart's squeezing, that systolic when it compresses down and it squeezes really tight, and diastolic when the ventricles open back up, and it's that motion of squeezing, opening, squeezing, opening, squeezing. So when that starts to get bear hugged on, that difference between systolic and diastolic contractions are going to get closer together. So imagine you got somebody doing a really big jumping jack and their arms, are sticking out, and then they go up and their arms go up to a point above their head and their feet below together. So that's kind of the difference between your systolic and your diastolic contractions. Now take a big burly man and go up to that person doing the jumping jacks and give them a bear hug. So the difference in their jumping jacks isn't going to be nearly as good. So in that pericardial tamponade, you're going to see that systolic and diastolic coming closer together just because those motions are getting closer and closer together. So you'll have that narrowing pulse pressure, whereas pulse pressure is the difference between your systolic and diastolic pressure. So that narrowing pulse pressure, JVD, because those ventricles can't open up as much because they're getting squeezed on, and chest pain, and muffled heart tones. Other direct injuries to that heart muscle can cause those dysrhythmias. Sinus tach is the most common, can send people into V-tach, V-fib, other crazy things such as that blunt force trauma immediately to the heart at the right millisecond sends it into V-fib, called commotio cordis. That is the instance that has caused little leaguers and other baseball players and other athletes to die. About every year, there's stories of youth pitchers in baseball taking line drives to the chest, and it hits them at the absolute right millisecond and sends them into V-fib. Those changes in shock are progressive, whether it is very fast or it's a slower onset. There are steps and it's sequential of how it all occurs. Those compensatory mechanisms, they are short term, and without interventions, they will ultimately fail, whether that's fail extremely soon or if it's over minutes, hours, even days. Those heart muscles, the heart itself has got to be at a good effective pump for that Starling's law to be in effect. So Stirling law is what increases or what relates to the stroke volume, so the amount of blood that's squeezed out of the heart each time. So Stirling's law is the force that goes back into it allows a good force to come back out. So imagine a rubber band. The more you pull back on that rubber band, the harder force is going to go out. So in instances of like neurogenic shock or anything that causes hypoperfusion, if there's not good pressure coming back into the heart, if it's starting to reduce in those vessels, the heart's not going to be able to push it out very much more. So you can't just get low fluid into the heart, then all of a sudden the heart will be able to, take one drop of water and make a gallon out of it. It's going to have good force to come back in to be able to squeeze and push it back out. And that cardiac output, talked before about that heart rate increasing to maintain that cardiac output. So if that stroke volume goes down, and that heart rate has to go up to compensate. So just kind of like a teeter-totter. Stroke volume goes down, the heart rate's going up to compensate to keep that cardiac output where the brain wants it to be. So with that adequate blood pressure, as that cardiac output is starting to go down, your blood pressure is going down just because that cardiac output with that systemic vascular resistance, meaning those vessels have good pressure on them to keep it circulated and good pressure to push back into the heart. Because if you've got just a really big vessel and a little bit of blood, and there's not going to be much pressure out of that to come back into the heart. And that vasoconstriction, while that's good for the body to compensate like that, those really small vessels and the most distal parts of our body, they're going to become ischemic because that vasoconstriction. So they are hypoperfusing. So in those microvascular, those early stages, the sphincters and those really small vessels are constricting. So ischemic tissues distal to where the sphincters have constricted. So in those little areas, there's coagulation, acidosis stuff starting to happen below that site from where those cells are not getting perfused. They're not in aerobic metabolism anymore, so they're going to anaerobic metabolism. So distal to those where those sphincters are constricted, acidosis is beginning to happen there. And as that acidosis increases, it's harder for those muscles and the vessels to constrict. The acid's just fighting against it, so those vessels are trying hard to constrict down, but that acid's fighting against it, working against those muscles to be able to maintain their strength. So as all that's happening, it's becoming more and more prominent. The acid's beginning to build. The body's having a harder and harder time to be able to fight it all off. So that stagnation of blood is occurring in those capillary beds, those acidotic cells from the anaerobic metabolism starting to cause major, just nasty stuff to build up in those extremities. So finally, in that post-capillary sphincters, as they relax, from all that acidosis, the body's lost its ability to stay constricted down. Then you got this washout phase. So all of this is a lot like diarrhea. So we've all had diarrhea before, and we talked about sphincters. So your butthole, it's a sphincter. So as we're getting diarrhea, our butts are constricted down, really, really tight, trying to make sure we don't poop ourselves. So as we're bearing down, we got our all of our sphincters contracted, trying to keep everything on the inside, trying to compensate the best we can so we don't leak everything out. And the more the acid's building up in our stomach, the harder it is for us to stay constricted. So the more our guts start to bubble, where it feels like our guts are on fire from the acid in there, then eventually we're not going to be able to constrict anymore. The sphincters aren't going to work, and they're going to end up relaxing and dilating, and then we're going to have that washout phase where we have to go wash out our underwear because we haven't been able to constrict those sphincters down any longer. With that hypoperfusion occurring and cellular hypoxia, of course our brain, heart, and lungs are by far the most important and the most sensitive to perfusion. After that, kidneys, liver, GI tract, they can go for a while without being perfused and still be fine. And then the very least sensitive, muscle, bone, skin, that stuff's much easier to heal than your brain, heart, or lungs is. Some of those patients who go into hyperperfusion for very long periods of time can end up developing acute renal failure. So some of these shock patients, while they're in the hospital, while they're being managed, they may end up on dialysis just to fix everything, get their body going back up because there's been so much acidosis, so much damage to those tissues that they're gonna need some help refiltering everything out. Another condition that occurs due to shock and hypoperfusion is ARDS, acute respiratory distress syndrome. So this comes from damage to those alveolar cells, those really microscopic cells, as they've been hypoperfused, and hyperresuscitation, just fluid overload. So basically it results in leaking of fluid into the interstitial spaces of the alveoli, just a lung tissue disease. A lot of times this can occur from even smaller things or be developed from hospital-acquired diseases. So you take this patient into a hospital who's in shock, they're hypoperfusing, so their immune system is crashed because of acidosis and a variety of other things. Just makes them very susceptible to not help, but to be able to pick up. They're acquiring these hospital-acquired diseases like hospital-acquired pneumonia, things like that. Um, Older populations, adults to geriatrics, a lot of times when they end up getting ARDS, they end up on a vent, and the probability of them getting off a vent is very slim. Pediatric patients, however, since they're so sensitive to this stuff, but we all know kids bounce back pretty easily. A lot of the kids who end up developing ARDS are able to fully recover from these conditions, which is a secondary injury to the initial primary injury that was occurred from the shock. And again, with that state of hypoperfusion, some major impaired clotting issues. So that could be from the hypothermia, the dilution of the clotting factors, because we've made your blood look like strawberry Kool-Aid because we overloaded them on crystalloid solution instead of them getting blood like they needed, or just an overall depletion of all those clotting factors. More renal failure stuff from that prolonged shock from that liver being hypoperfused from so long, and overwhelming infection. As I said, whenever all your cells and all your organs are under attack from acid and hypoperfusion and cellular death, your immune system's not very good. So immune system's crashed, and you got that loss of energy and just loss of the body's ability to fight off infections, especially when you end up being in a hospital. And well, everybody in a hospital's sick, so with no immune system, you're surrounded by really sick people. Chances of yourself picking up a hospital-acquired disease is very high. So during assessment of these patients, we've got to evaluate any life threats we come up to first. And of course, bleeding takes priority, life-threatening bleeding takes priority over everything else. So if your patient's bleeding and all those blood cells, they're going to carry the oxygen or pumping into the grass, bagging them is not going to do anything because the whole transport system is not inside the body where it needs to be. So we're evaluating that level of consciousness. As we remember in that previous chart, when you're starting to see those mental status changes is a late sign, and that being one of our, in our first primary assessments, that level of consciousness and general impression ties into that. So you go up to this patient and you already see that they've got a mental status change, or they're lethargic, near syncope. Should immediately throw up that flag before you're even touching the patient that something's drastically wrong, and immediately checking their skin, which will help you identify their perfusion status. So if their skin's cold, generally no ATP production, especially if you're feeling and their skin's cool, there's no radial pulse, they have increased respiratory rate. So with that tachycardia, cool skin, no radial pulse, you ought to immediately know this patient is already in decompensated shock. Control all hemorrhage. You gotta control all the bleeding, because essentially every single red blood cell counts. Assessing that level of consciousness, any cause of hypoperfusion is going to start to affect the mental status as well. So again, that brain, heart, lungs being the most sensitive organs. So if you're hypoperfusing, your brain is taking over everything. It's really needy. It's kind of like Goldilocks, wants everything just to be its way. So if it's starting to have cerebral hypoperfusion, you're going to start getting that altered mental status. The skin, we're always looking for skin color, temperature, condition, and capillary refill. Granted, it's not that reliable in adults, but still a tool that you can use. So with that skin, if it's cool, means that there's probably there's a reduced amount of ATP production, so less of a chemical reaction, so less heat production. If your skin is kind of sweaty, that's from those adrenic receptors kicking in and that epinephrine being released, because when our adrenaline releases, what do? We get sweaty. So you got this cool patient who's sweating, and they've got poor capillary refill, and they've got either no radial pulse or it's fast. If you feel radial pulse and it seems to be a little tachycardic, and you've got a little bit of cool skin and maybe a slight mental status change, can let you know right away too that this patient's possibly in decompensated shock, that you've got, that load and go patient. Another little handy dandy chart of assessing those things with based on your primary assessment and your skin conditions. So hypovolemic cardiogenic shock, they're gonna pretty much present the same exact way. That neurogenic shock is where your skin can still be warm and dry and pink, just everything's hypoperfusing and you've got a low blood pressure. And assessing those respirations, increased respiratory rate, that heart speeding up, trying to compensate cardiac output. The heart increases its demand. It needs more oxygen, so it makes you breathe faster to try to get in more oxygen. You have hypercarbia, buildup of CO2. Your body's trying to maintain its pH balance, so it can be trying to blow off acid. So, of course, our main primary sensory for breathing is that Abdullah oblongata, and it measures the amount of CO2 in our body. So it's measuring the amount of CO2, amount of acid, trying to blow it off. So that increased ventilatory rate might just be that first indicator that the patient is going into shock. And then maybe that intolerance of a non-rebreather just because their anxiety levels are a little bit high. Another indicator of those first few phases of the body's compensatory mechanisms for shock. Then that blood pressure. Blood pressure is not a determining factor of shock. So you're going to end up losing 30% of the blood before your blood pressure becomes hypotensive. So not always the best indicator that whether the patient's in shock or not. The infamous saying of treat your patient, not the monitor. Lots of detective work hats here, lots of differential diagnosis stuff of really truly trying to evaluate your patient to see if they are compensating or not. And then thinking about those other underlying complicating factors like the patient's age, any medicines they're on, are they on any beta blockers? Have they, overdosed on anxiety meds, or taking a bunch of Xanaxes? Have they taken some other kind of street drugs that could be downers and reduce that compensatory mechanism for the heart rate to speed up? With pregnancy, if the patient's pregnant, there's going to be an increased amount of blood within the body. So then that amount of going to decompensated could mean that they've lost more than 2 liters of blood because there's a lot more in there, or any other underlying conditions such as anemia, any other kind of thyroid disorder that already might throw them in a hypothermia quicker. Here's a thought on a non-traditional kind of assessment for a shock or trauma patient. So talking again about Krebs cycle, that oxygen plus glucose equals ATP. One of the byproducts of ATP is CO2. Do we have the ability to measure amounts of CO2? We do, capnography. So with capnography, we can measure the amount of CO2. So if the patient's in shock and beginning to hypoperfuse, there's not much ATP production. So in these trauma patients, we can be measuring their amount of CO2. So if they are hypocapnic, low levels of CO2, very good assessment that that patient is hypoperfusing. Now granted, that can vary on a few things. If the patient's hyperventilating and blowing off a bunch of CO2, it's kind of one of those hard things to differentially diagnose. But if we've got still semi-decent perfusion, still got we don't have a VQ mismatch, we can put that patient on capnography, see if their end tidal readings are a little bit low to see if they're actually going into shock. And then we can be using that too to measure if we're giving fluid or treating that patient, if their CO2 levels are improving and they're not holding their breath, that if their CO2 levels are improving back into that 35 to 45 range, our treatment's working. In closing, here is some newer information that has kind of come out. There has been recently a lot of studies that have been conducted to say that this chart that PHLS produces about um, going off of blood pressure and other vital signs to indicate what stage of shock they're in, that it may not always necessarily be true. A recent study that was conducted over a span of about 9 years and involved about 40,000 patients stated that this chart was only accurate for about 20% of the patients. And a lot of the researchers just alluded that you really do just have to really assess a patient. You can't, everybody's different. You can't go off the same chart. But one thing that has kind of been developed is this thought of a shock index. So shock index is you take their heart rate and you divide it by their systolic pressure. So normal should be less than 0.5. So if you were to take a patient's heart rate, normal heart rate, let's say 60, and we're going to divide that by, normal blood pressure 120 over 80. That equals 0.5. Okay, so if a patient has been involved in a traumatic injury and has been untreated, so mind you, all these numbers are that patient being untreated, unmedicated, just your initial findings is if you have a shock index of more than 0.5, so 0.6 to 0.9 means that they have lost about 20% of their blood volume. So 500, 750, which, goes on to this. Okay, so all that kind of still compares to class 1 shock, and all the research still says that the treatment should still be the same. Whereas when it gets higher from, around 1 is equaling your 1,000 to 1,500 milliliters of blood, 20 to 30% of your blood loss, which still is pretty close to what this chart says here. And then anything about over 1.5, close to that range, and that's getting up between 1,500 2,500 milliliters of blood, 30 to 50% of your blood loss. Still pretty close to what this chart's saying. And then finally, anything over 2, you've lost over half your blood volume. So if you've got that patient who's got that blood pressure of heart rate of 120, and now their pressure is only 60, which we've probably seen those patients before. That loss of blood volume also kind of closely correlates to their morbidity rate. So you've got a patient over a 2, about 50% chance that that patient's probably gonna die. So that's just kind of one of the newer things that's come out of, I think the study finished up in 2011, talking about that a shock index was a really good indicator evaluating your patient too, whether where they're at in blood loss, whether they're actually compensating or not, and how well they are. But still, again, all the numbers, all the charts cannot supersede your assessment abilities of checking out everything, using all your gadgetry, actually feeling, looking at your patient, talking to him, checking everything out. So, any questions, always reach out to us, and thank you for watching.